Hello guys, today we're going to learn about diabetes insipidus. Diabetes means excessive urine formation and insipidus means tasteless. So in case of diabetes insipidus, tasteless urine is formed, whereas in diabetes mellitus, the urine is actually sweet. When there is a increase in blood osmolality, or when there is a decreased water in the blood, it is sensed by osmoreceptors in the hypothalamus, and these osmoreceptors will do mainly two functions. Okay, one is they will increase the sensation of thirst and the person will tend to drink more water. Another is they will stimulate a nucleus called supraoptic nucleus present in the hypothalamus, and these nucleuses are responsible for the production of the ADH hormone, which is antidiuretic hormone. These hormones are formed in the supraoptic nucleus and they will travel all the way to posterior pituitary gland through the supraoptico-hypophyseal tract, which is present in this pituitary stalk. And when they are stored in this posterior pituitary gland and released into the blood. When released in the blood, this ADH hormone will travel to the kidney and they will act on the distal convoluted tubule as well as the collecting duct of the kidney. In the kidney, they will bind to this receptor on the basal side of the principal cells of the collecting duct, and these receptors are B2 receptors, arginine vasopressin 2 receptors, and when ADH binds to these receptors, they will form a few channels known as the aquaporin channels. So these are the aquaporin channels. These channels will embed into the apical side of these cells, and as their name state, they will reabsorb water from the lumen of the tubules. Okay, so these aquaporin channels will absorb water from the tubular lumen, and they will send water into the cell through which they will travel into the blood. And as water reaches to the blood, they will dilute the blood. They will decrease the blood osmolality. That is also sensed by the osmoreceptors, and it will reduce the formation of the ADH. So this is the normal physiology. Let's come to the pathology, which is the diabetes insipidus, that is caused when there is lack of formation of the ADH or when there is inability of kidney to respond to ADH. Now, when there is defect in this supraoptic nucleus or defect in any part of the pituitary stalk, or when pituitary gland fails to release the ADH hormone into the blood, they will produce lack of ADH in the blood, and that can lead to diabetes insipidus. And another is when the production is normal but the kidney fails to respond to ADH hormone, when there is any mutation to these receptors or when there are any presence of kidney diseases, then the kidney fails to respond to ADH, and that can lead to diabetes insipidus. It is characterized by polyuria and polydipsia. Okay, so when the ADH cannot function, there is no formation of these channels, aquaporin channels. So when there is no formation of aquaporin channels, water cannot get reabsorbed, and this water will get excreted through urine. So there is unusual amount of urine is formed, and that is known as polyuria. And as this water cannot get into the blood, the blood osmolality is increased. It is sensed by the osmoreceptors, and they will increase the sensation of thirst, and the person tend to drink more amount of water, which is known as polydipsia. These are the biochemical abnormalities in diabetes insipidus. The urine volume is increased by more than 3 liters per day, and surprisingly sometimes it can reach even up to 20 liters per day. The urine osmolality is decreased as there is more amount of water in the urine, and it is less than 300 milliosmol per kg, and normally urine osmolality is counted between 300 to 900 milliosmol per kg. Serum osmolality, normally it should be between 275 to 295 milliosmol per kg, is increased in case of diabetes insipidus, more than 295 milliosmol per kg. And serum sodium is also increased, that is more than 145 milliequivalent per liter. Normally it is between 135 to 145 milliequivalent per liter. Now let's come to the types of diabetes insipidus. The first one is the central diabetes insipidus. In the central diabetes insipidus, there is a defect in this part which I've highlighted in red. When the osmoreceptors fail to sense the osmolality of the blood, or when the supraoptic nucleus cannot produce the ADH, when there is any defect in the pituitary stalk that affects the transportation of the ADH hormone, or when the pituitary gland fails to release the ADH into the blood, this is called as central diabetes insipidus. These are all the causes of the central diabetes insipidus. The hypothalamic lesions such as adenomas, craniophryngiomas, pituitary lesions such as adenomas, leukemias, sarcoidosis, histiocytosis, or other causes such as neurosurgery, radiotherapy, severe head injuries, hypertension, meningitis, and unknown cause, that is idiopathic. Next one is the nephrogenic diabetes insipidus, when there is defect in the nephrons. Okay, so in any kind of genetic mutations in these receptors, are kidney diseases, polycystic kidney diseases, or use of drugs such as lithium, which reduces the number of echoporins in the cells. This can lead to nephrogenic diabetes insipidus, and these are all the causes. When the cause is unknown, it is idiopathic. It can be secondary to hypercalcemia, hypokalemia, sickle cell diseases, pyelonephritis, sarcoidosis, or use of drugs such as lithium, demiclocycline, colchicine, etc. Central diabetes insipidus versus nephrogenic diabetes insipidus. In central diabetes insipidus, there is a defect in the production of the ADH, so the ADH level is below normal, that is less than 1 picogram per ml, whereas in nephrogenic diabetes insipidus, ADH production is not affected, so the plasma level of ADH is between normal, that is 1 to 5 picogram per ml. But this ADH, it fails to act on the kidney, so that's why we call it as nephrogenic diabetes insipidus. The next one is gestational diabetes insipidus. In gestational diabetes insipidus, trophoblast cells found in the placenta will produce vasopressinase enzyme. This enzyme will break down ADH or vasopressin, and the vasopressin cannot function, and that can lead to diabetes insipidus. The production of vasopressinase starts from the 8th week of pregnancy, and it peaks at third trimester. So the symptoms are mainly seen in the third trimester, and after taking out of placenta from the mother, the symptoms can still be seen up to 4 to 6 weeks after postpartum due to presence of any residual vasopressinase enzymes. The fourth one is dipsogenic diabetes insipidus. Any patient with psychological defect, he drinks a lot of water, due to which there is reabsorption of the water and decreased blood osmolality. Decreased blood osmolality is sensed by the osmoreceptors, and they will reduce the production of the ADH from the hypothalamus. And if the ADH cannot function, then there is no reabsorption of water from the kidney that can lead to polyuria. The biochemical tests that can be done for the diagnosis of diabetes insipidus are urine osmolality upon plasma osmolality, water deprivation test, and the DDABP test. The ratio of urine osmolality and plasma osmolality. Normally, urine osmolality and plasma osmolality have same values, that is around 300 milliosmol per kg. So the ratio is 1. But if the ratio is less than 1, then we can consider it as diabetes insipidus, where the urine osmolality is less than that of plasma osmolality. But if the ratio is more than 1, then we can consider it as osmotic diuresis, where the plasma osmolality is less than urine osmolality. So if you consider diabetes insipidus, to confirm it, we can do water deprivation test. So the principle here is the restriction of water intake for some hours. This will increase the blood osmolality, and this will stimulate ADH secretion from the hypothalamus. And when there is ADH secretion, there is maximal water reabsorption, and if there is water reabsorption from the urine, then there is production of the concentrated urine. Okay, and the procedure here is the patient is kept on NPO, nil per os, for some hours, and we do the hourly testing of the urine and the serum osmolality. And on the interpretation, if the urine osmolality is increased, that is more than 300 milliosmol per kg, and if the plasma osmolality is in normal, then the then there is no any diabetes insipidus. But if the urine osmolality remains below 300 milliosmol per kg and plasma osmolality is increased, that is more than 295 milliosmol per kg, then diabetes insipidus is confirmed. And after diabetes insipidus is confirmed, we can do DDABP test and to differentiate it from the central diabetes insipidus and nephrogenic diabetes insipidus. DDABP stands for des-amino des-aspartate arginine vasopressin, which is also known as desmopressin acetate. It is an ADH analog with a longer half-life. In the procedure, we provide DDABP 2 mg intramuscularly or 5 mg intranasally, and we check the urine osmolality. And if the urine osmolality is found to be greater than 750 milliosmol per kg, that is, previously there would be lack of ADH in the blood, so we can consider it as central diabetes insipidus. But if the urine osmolality remains below 300 milliosmol per kg, then we can say that there is resistance to ADH in the kidney, so that is nephrogenic diabetes insipidus. And on the treatment, you need to drink more water to correct any high blood osmolality, and this can be done in central nephrogenic and gestational diabetes insipidus, but we do not do it in dipsogenic diabetes insipidus, as there is a reduced blood osmolality. Desmopressin can be given for central and gestational diabetes insipidus, as there is lack of ADH in the blood. Thiazide diuretics is given in nephrogenic diabetes insipidus because these diuretics will create an environment of mild hypovolemia, and when there is hypovolemia, this encourages more water and salt intake from the kidney tubules, and that will reduce polyuria. Amiloride can be given in lithium-induced nephrogenic diabetes insipidus, as this will reduce the transcellular transport of the lithium and intracellular concentration of the lithium. So this much for today about the diabetes insipidus. Thank you.